Hello, my name is Samantha. I'm going to be talking to you about the respiratory system. So, the respiratory system includes the upper and lower airways. The upper airways includes the nose, the pharynx, the larynx, and the trachea, which all work like a system of pipes through which the air is funneled down into the lungs. The upper airway needs to stay open in order for us to breathe, and also helps moisten and warm the air before it enters the lower airways, which is the bronchi and the lungs. The lungs have very small air sacs called alveoli, where oxygen is brought into the bloodstream and carbon dioxide, which is a waste product, is pushed from the blood out into the air. The lungs take up most of the space in our chest along with the heart. So the role of the lungs is to take oxygen to the body and help us get rid of the waste product, carbon dioxide. So the right lung has 3 lobes, where the left lung only has 2 lobes because the left lung is on the left side of the chest along with the heart. So how the lungs work. Air enters your lungs through a system of pipes called the bronchi. The bronchi start from the bottom of the trachea as the left and right bronchi branch out throughout the lungs until they eventually form thin little air sacs called the alveoli. The alveoli is where gas exchange takes place between the air and your bloodstream. So, when you breathe in, air comes down the trachea through the bronchi into the alveoli. The fresh air has lots of oxygen in it, and some of the oxygen will travel across the walls of the alveoli into your bloodstream. Traveling in the opposite direction is carbon dioxide, which crosses from the blood in the capillaries into the air in the alveoli, and it is then breathed out. In this way, you bring into your body the oxygen you need to live and get rid of the waste product known as carbon dioxide. So that's inhalation, exhalation.
Now we're going to do the assessment part of the respiratory assessment. We're going to inspect, palpate, percuss, and auscultate. The first step is we're going to go into the room and introduce ourselves to the patient and tell them what we're doing.
Hi, Riley. My name is Sadie. I'm going to be listening to your lungs today, okay?
Okay. You're going to get their name and date of birth.
Okay, so I'm checking for name, date of birth.
The first part is inspection. We're going to visually assess the rise and fall of the chest.
Can you breathe in and out for me?
We're going to see their work of breathing and respiratory rate. Their respiration should be easy, unlabored, within 12 to 20 breaths a minute. Over 20 would be tachypnea. Under 12 would be bradypnea. There's also apnea, which is an absence of respirations for several seconds, which can lead to respiratory arrest. Dyspnea, which is difficulty breathing, gasping for air. Cheyne-Stokes, which are shallow, slow, labored respiration with periods of apnea. This is often seen in a dying patient. The patient can also be hyperventilating. Over 20 breaths a minute would be considered moderate. Over 30 breaths a minute would be considered severe. Causes for this would be pain or panicking. This decreases the carbon dioxide in the blood and causes numbness, tingling in the hands. We can also assess the color of the lips for cyanosis. And check for the position of the scapula and shape of the chest. Make sure the sternum is midline, the shoulders are symmetric.
Okay, so at this time I'm just observing and looking, just using any accessory muscles, symmetric, and the respiration rate.
The second part of a respiratory assessment is palpation. We're going to feel the back for any tenderness. At the same time, Sadie is assessing for any crepitus, which is a crackling sensation.
So I don't feel any crackling. And do you have any pain as I go down, Riley?
Mm-hmm. Next, we're going to assess for any fremitus, which is palpable vibration of the chest wall resulting from speech. There are 2 ways you can do this. The first is using the ulnar surface of your hand to the chest wall and having the patient say 99.
Can you say 99?
Again. We're going to repeat this on the front. The second way we can do this is using the palmar surface of your fingers to the chest wall, and again having the patient say 99. This is increased by conditions that cause the lungs to become more solid, like consolidation, fluid, or masses, and decreased by conditions that decrease transmission of sound waves, like increased fat, overexpansion of the lungs from emphysema. And at the same time, we're also going to be assessing for any surface characteristics or abnormalities on the skin.
So any bumps or anything abnormal.
The third step is percussion. The normal sound is resonance. Other sounds we can hear are hyperresonance, which can be due to emphysema or pneumothorax, and dullness, which can be due to consolidation, pulmonary embolism, or tumor.
Breathe in and out.
To auscultate the lungs, have the patient sit straight up and begin on the back. Using a zigzag pattern, go from side to side of the spine in between the scapula, listening to a full breath sound in each spot, finishing along the T12 vertebral line. From the front, listen on both sides of the chest right above the clavicle, then in the second, fifth, and sixth intercostal spaces on both sides of the sternum. While auscultating the lungs, the normal lung sounds that are heard are vesicular, which are soft and low-pitched and heard over the entire lung field, except the upper sternum and between the scapula. Bronchovesicular are medium intensity and pitch, and are heard between the scapula and the first and second intercostal spaces anteriorly, and bronchial, which are loud and high-pitched and are heard over the manubrium. While listening to lung sounds, the nurse must pay attention to any abnormal or adventitious breath sounds. Crackles are associated with fluid in the airway or alveoli. Coarse crackles are associated with obstructive pulmonary disease, fine crackles with interstitial pneumonia, and generalized crackles with heart failure and pulmonary fibrosis. Wheezes, when high-pitched, are associated with bronchospasm, asthma, and buildup of secretions. Bronchial wheezes that are deep and low-pitched associated with secretions or tumor. Pleural friction rubs are harsh, crackling sounds, like leather rubbing together, that arise from inflammation and loss of pleural fluid. Stridor is a high-pitched and musical-sounding breath sound. It is caused by blockage or narrowing in the upper airways and is often audible without a stethoscope.